Treatment outcomes of regenerative endodontic procedures in traumatized immature permanent necrotic teeth by Cheng et al. From the Department of Pediatric Dentistry, Wuhan University, China. The aim of this study was to evaluate the clinical and radiographic outcomes of regenerative endodontic procedure for traumatized immature permanent necrotic teeth. Data were obtained from the dental records of all patients who received regenerative endodontic procedure from January 2012 to September 2021 at the Department of Pediatric Dentistry. The inclusion criteria were patients who had a minimum of one traumatized, immature permanent necrotic incisor treated by regenerative endodontic procedure and had a follow-up period of at least 6 months. As we can see here in Table 1, 39 patients in this study has experienced a fracture injury, 6 patients experienced luxation injury, 14 patients experienced combined injury, and 3 patients experienced avulsion. For the radiographic analysis, the apical diameter was measured as the distance between the mesial and distal apical root ends, as we can see in Figure 1a. In Figure 1b, the straight line between the cemento-enamel junction and the midpoint of the apical diameter was measured mesially and distally, which was then averaged as the root length. For Figure C and D, the radiographic root area was defined as the difference between the total root area in Figure C and root canal space in Figure D. For the clinical protocol, at the first appointment, access to the pulp canal chamber and gentle irrigation with sodium hypochlorite, followed by minimal or no instrumentation. Triple antibiotic paste or calcium hydroxide was placed as intercanal medicament, and teeth were sealed for 2 weeks. At the next appointment, teeth were re-accessed and disinfected with sodium hypochlorite, and a pre-curved K-file at 2 mm past the apical foramen was used to induce bleeding into the canal to the level of cemento-enamel junction. An alternative to creating blood clot was the use of concentrated growth factor, which was prepared from the patient's intravenous blood. The definition of outcomes: success if the absence of any clinical and radiographic signs or symptoms except for root canal obliteration or its associated crown discoloration. Survival if the tooth retained in the arch without clinical signs or symptoms regardless of radiographic signs of disease. Failure when the presence of clinical signs or symptoms, persistence of or increased periapical radiolucency, root resorption, or additional intervention after regenerative endodontic procedure. For the results, almost 81% had a successful outcome, and 85.5% were asymptomatic and functional, defined as survival. Of all the traumatic teeth, the highest success rate was attributed to teeth with fracture, which was 84.6%, followed by luxation, which was 83.3%, and combined injury was 78.6%. Teeth suffering avulsion had the lowest success rate, which was 33.3%. Additional intervention in the failed teeth included extraction in one tooth, root canal treatment in one tooth, and decoronation in one tooth, and apexification in 6 teeth. In addition, almost 34% of teeth exhibited discoloration. For the radiographic outcome, it showed that 69.3% decrease in the apical diameter and 10.2% and 22.6% increase in the root length and radiographic root area respectively. In conclusion, based on this result, regenerative endodontic procedure provides satisfactory treatment outcomes in traumatized immature permanent necrotic teeth. However, severe injuries, especially avulsion, should be determined carefully before performing this procedure. When resorption is expected, changes in the apical diameter and radiographic root area can be expected. The effect of regenerative endodontic procedure on root length seems to be limited. The induced bleeding technique appears to be more appropriate for the management of traumatized teeth with regenerative endodontic procedure.